Hello and welcome to our session, Briefing Center on Rethinking Obesity Care. I'm Pranjal Sharma, and I'll be joined in a conversation with Camilla, Sylvest, and Duffy. We're jumping right into the thought about the fact that we have over 1 billion people who are impacted by obesity, and both in high-income countries as well as in low-income countries. So what are the ways in which that this can be combated, both from a social behavior perspective as well as a medical perspective? So I'm going to request Camilla to begin and share some of the thoughts from her perspective and what the pharmaceutical industry is looking at, because it's as much a healthcare problem as a social problem. So how would you like to address this?
Yeah, first of all, I'd like to say that obesity is really something that is increasingly prevalent in all countries of the world. And there was a time when we thought this was more in developing countries, but actually the prevalence of obesity is extremely high in most countries of the world by now. Unfortunately, we know that we are reaching close to 1 billion people living with overweight or obesity, and especially concerning are the prevalence, the increase in the prevalence amongst children. We know that more than between 300 and 400 million children are living with severe overweight or obesity. And we also know that 80% of those are likely to grow up, continue living with obesity. So there's no doubt that this is a huge healthcare problem that is not only a health problem, but also an economic problem, because forecasts estimate that it will have a negative impact on global GDP of approximately 3 percentage points in 2050. So there are lots of reasons to talk about how do we tackle this.
Sean, how would you approach this? How do you see, because you provide this care and you are looking at it really closely?
Well, just to echo Camilla, I mean, the trends are harrowing. The closer you look at the epidemiology, the scarier it gets. It's gotten worse every year since I founded the company, 10 years ago. Equally, from an opportunistic side, I think it's the most exciting time from an innovation standpoint in obesity medicine. Because fundamentally, obesity is the combination of biology and behavior. And just now, I mean, you're seeing this with, I think, both of us. There are biological approaches, GLP-1s, which are shown to be extraordinarily effective. There are scaled behavioral approaches, which Omada is part of, that take evidence-based lifestyle intervention and work to gain access, scale it, and have a access spread through technology. And then even better, they're starting to intersect right now. So it's almost like a thank goodness moment, because the trends are so scary that innovative solutions really fundamentally have to be here for the health of the globe.
But this concept of innovation, there are some very interesting innovations happening which are benefiting patients, but it tends to give the impression that don't change anything, just take this wonderful little pill and it's going to get you back to normal weight. Isn't that a risk? And I would request both of you to comment on this.
Yes, so first of all, I'd like to say that, of course, different people living with obesity has the need of different types of treatments or behavioral interventions. But if we're talking about those who are on a GLP-1 therapy, most of them are on a once-weekly injection. And of those, we clearly see that the average impact on their weight, of course, is significant, but also that the GLP-1s are able to reduce long-term complications like diabetes, like cardiovascular disease. And we know obesity is the leading cause of diabetes and is also leading to other serious chronic diseases like cardiovascular disease and chronic kidney disease. So we need to do something to prevent that, because that is not only a health problem, but also an economic problem, as we talked about before. I do think that when we now have new evidence in our hands that we can truly manage this problem, it is important to look at not just the population of people living with obesity as one group. There will be different needs, and you will see some people need to continue treatment. Others may get to a healthy BMI where they can then sustain that, potentially via behavioral modification or other things, and others again would constantly have to increase the level of GLP-1 treatment, for example, to keep a healthy weight. So we cannot talk about a group of 1 billion people as just one group anymore. And we are learning as we go from research, from real-world evidence, to become more and more sophisticated about these different types of people.
But Sean, when we talk about novel therapeutics, it should be enveloped in education, in helping people understand what they're doing. It cannot be that, okay, there's a wonder pill and we go with it. I'm persisting with this simply because there is this tendency of convenience. So we know, we talked about convenience food being a factor for obesity, but then you're combating convenience food with convenience pills. Now, are we sort of supporting one ill with another ill?
You know, look, this is a disease area where it's hard to find a silver bullet. I don't think there ever will be a silver bullet. It's going to require a combination of tools, a combination of approaches. I founded Omada Health while in medical school, and I never imagined, I was hoped that there would be a therapeutic that could be effective to be part of the toolkit. Wonderful, there is. You know, our goal at Omada is to scale lifestyle interventions so they can have so many across the country, the globe can have access to them. That's happening. So I think it's multifactorial. Per Camilla, I think each person is different. Each person will respond differently to different approaches, and frankly, we need as many effective interventions as possible. In this disease.
And this is no longer an individual issue, as you're saying. It's a social issue. That means that there has to be some level of collaboration between various stakeholders to be able to highlight how to prevent it. You cannot just say the onus is on one person or the person, it was their problem, they created it, they have to deal with it.
Absolutely. And in previous years, there's been a lot of stigma around people living with obesity. There's been the understanding that if they could just get their act together, eat more healthy and exercise more, then they could have solved that problem for themselves. And also that the problem was just a cosmetic problem. But what we know now is that neither of these things are true. Some people are more predisposed for obesity and are living in socioeconomic environments where this is provoked more than in other socioeconomic environments. We clearly know that. And we know, of course, also that children living with two parents living with obesity have more than 80% likelihood of living with obesity when they grow up. So there's a lot that we need to do about this that doesn't only have to do with the behavior of the individual, but of course we need to also support that. And we all know what are sort of, if I may say so, correct behaviors, but we also all know how difficult it is to sustain that. And I have a lot of respect for Sean and his team on how they have actually, with behavioral modification, enabled people to change that. But we also know for the vast majority of the rest of people, they are not able to necessarily sustain a healthy weight that will prevent them from these long-term complications. So we need to help that. And now we have also medicines available to do that. So I don't think any of you would think about, for example, high blood pressure as a thing that people should just relax a bit more and maybe not put pressure on themselves, and then the high blood pressure would go away, and then good luck with that, and that was the end of that story. We just don't think about other diseases like that, so we shouldn't be thinking about obesity as if people can just fix this on their own. I think we have learned that obesity is a disease, as it's also recognized by the WHO.
Actually, that's a great point, Camilla, because obesity leads and triggers so many other problems. So you don't even have to see it in isolation. It is at the fount of triggering other problems, which again impacts maybe a family unit, because if one person is impacted, then the rest of the family unit has it is a cascading negative effect. You used a very interesting phrase, Sean. You talked about biology and behavior. Are there examples of good behavior change which can be seen as benchmark for people to emulate?
Well, I mean, there are evidence-based approaches that have been shown to work. There are those that don't. Principles in the ones that work tend to be not telling people what to do, but listening to their goals, understanding their social circumstances, kind of, gently gliding them to different mindsets relative to eating behaviors, physical activity behaviors. And there's an art and a science to effective lifestyle interventions. And the literature are there. I mean, there are many foundational studies that show you can move the needle. The tricky thing is it's very, very hard to do. It's even harder to do that at scale. And so that's the era, that we're in with technology. It kind of enables, broader access to these evidence-based programs that can be one tool in the toolkit, similar to GLPs.
So scale is the critical part, right? So there's scale, I would say diversity of patients. So it could be young children, it could be older people. It's also geographical diversity. It is language diversity. So if you're trying to communicate a new behavior. You have to do it not just in one way. You have to look at what will work for each community which is getting impacted. With this context, what kind of partnerships should be put in place? Because it is a global issue, but it has to be resolved locally and regionally.
Yeah, maybe I can start on a sort of a regional basis. So we have been working with a project called Cities for Better Health for the last 10 years, where we in more than 50 mega cities around the world, so Toronto, Vancouver, and it could also be Johannesburg, could be Shanghai, and so on. We are looking at what does it take to actually create the conditions that Sean was talking about to enable people to actually exercise and have access to healthy food. And I just want to say that the challenges are different in Shanghai as they are in Copenhagen, as they are in Houston. And so we understand from working with cities and mayors that are able to take action quite fast, that we are able to overcome some of these challenges. And that's more on a city level, but of course these are mega cities, where I think we actually have an opportunity to work together, companies, politicians locally, but of course also NGOs and other organizations that wants to change this. So that's what we can do on sort of more a structural level. But of course I know that Sean, you're working on it also on an individual level.
Yeah, and I mean, we're US based. In the US, we work with over 2,000 customers. For us, that's either an employer who's self-insured, a health plan, a PBM. One unique thing that we love is when we work with the employers, where our discussions actually go beyond the interventions we offer for their employees. They're asking us, well, what are your thoughts on the food we feed our employees? Like, could you, based on kind of your expertise here, are there things culturally we can adjust and change? Because people spend a lot of time at work. And that's a microenvironment that impacts your behaviors in subtle, nuanced ways. And so it really is an example of an environmental shaping that can create more positive outcomes for those in Omada's programs. And so again, I think the strategies have to be holistic. They have to consider the person, they have to consider the biology, the genetics, their microenvironment, and just kind of the tough realities. And that it's pretty easy over decades of a difficult food environment to gain weight. It's very hard to lose it.
Let's get some questions from some of you. If you have any thoughts or ideas to share, we can have a couple of mics with you. So if you'd like to raise a point with the experts or share an example which is worth understanding.
Hi there, Alexander Hoffman from Switzerland. One part that I'm really interested in is everything around the prevention of more acute episodes later on, like cardiac events or things like that. Therapies that help with obesity will obviously in future prevent diabetes, prevent things like that. So how do you, let's say in your respective lines of business, manage to price, let's say, that today for future benefits? Let's say I'm really interested to know how you approach that.
Yeah, so if I start on from a Novo Nordisk point of view, what we are doing is to do large outcomes trials that actually shows what happens based on exposure to GLP-1. How can we reduce the risk of some of those comorbidities? So we have big data, big studies now that is run for more than 4 years with more than 17,500 people, where we're actually able to say that we can statistically reduce the onset of comorbidities like diabetes, like cardiovascular death, and so on. So that, and then also real-world evidence, picking up the data from people who are exposed to this in a more real-life setting, whether we can sort of repeat these results is what we are also looking at the moment. It's extremely important to keep understanding who actually benefits more, and how do we potentially also predict within the first weeks of treatment what is likely to be the result for this particular patient. So in some of our you can say research centers in Oxford and in other places in Boston, we are looking at how can we try to predict for the individual patient to support the guidance of the doctor in terms of what is a good approach here. Then if I may just add one thing, we have also initiated a transformational prevention unit, which is basically using our insights into science to understand how can we predict who is going to be living with obesity based on socioeconomic factors and also based on inherited issues. And with the combination of that, we may be actually able to target also in terms of prevention those particular people more directly than educating, for example, all school classes, right? But we may actually be able to be even more specific. And with that, we can hope that we can try to prevent the problem becoming bigger. This is, of course, a little further out, but we have put this together between our research department and our, you can say, public affairs area and commercial space, simply to understand how can we bring prevention efforts better to healthcare systems.
And I mean, our answer is quite similar. Our customers expect us to show clinical and economic outcomes, and so we publish them. We have 29 peer-reviewed publications, ranging from observational studies to level 1 evidence that we work with academic medical sponsors to study.
Any other question from anyone? Yes.
My name is Catherine Werner. I work for a German newspaper. Could you speak a little bit about the market for GLP-1 drugs? Like, what growth do you expect, and what impact is that going to have on the disappearance of obesity potentially?
Yeah, so what I can say is that in most physician guidelines, especially in the US and also in Europe, GLP-1s have been adopted into the physicians' guidelines as first line of treatment. And this is, of course, due to the benefits that those particular classes of drugs have. I'm not allowed to talk about the particular benefits here in Europe because of the audience, and I'm not a doctor. But what I can say is that, of course, what is really important about obesity is not just to lower the weight, but also the risk of comorbidities, which are what is really costly to society. And that's why we see this class growing. And we also see that studies have shown that other types of indications have been relevant. Could be fatty liver disease or other things that GLP-1s are being tested for. So this class is expanding, and it's likely to continue to grow. I think that's what I can say about this, in a public forum.
One quick question I have: how can technology play a role? What are the ways in which technology can be used to both prevention and for care?
Well, I mean, they can complement the medicines. So we launched what we call a GLP-1 care track within the Omada solution. That's a personalized layer that we turn on if someone's on a GLP. And there's really two primary goals. One, optimize for on-therapeutic outcomes. Injections are amazing. They don't tend to get to know you. They don't, listen to you about your eating routines over the course of a week. They don't say, hey, now that you've lost 10%, let's think about new physical activity you can do. And so against that rubric, you can really complement the therapeutic benefit. And sometimes our members tell us, look, a GLP got the boulder rolling down the hill. I believed that I could lose weight, maybe for the first time in my life. And then I was ready to listen to, what Omada had to say, and really start to tune and refine some of my lifestyle in ways that I have never been able to do before. So that's an example.
Anything from you, Camilla? And how do you see? I mean, are there, for example, for education, for improving the understanding of the challenges and the cascading effect? Are there ways in which we have fantastic, very influential social media platforms? Have they been leveraged?
Yes, I think it's important to inform people about obesity and what it is. There's been a lot of, as we talked about, stigma and misunderstandings, and just making information available for people about what is obesity, where does it come from, what are the perspectives of it, why should I go and see a doctor or not. And it's not about sort of inventing a disease or making people feel ill. It's more about informing them. And then they will, of course, make their choice. So I think having that level of information, which that was not available just a few years back. I think just having that dialogue we just talked about before this session, that the stigma that there has been around obesity and the ability to now talk more about it may also help in other disease areas, could be on mental health or other things, that it's now okay to say that people are suffering from these things, and it's not just their own fault.
It's also enabled better conversations between physicians and and their patients. So I founded the company in medical school. I think, years ago, it was harder for doctors to talk to their patients about obesity. I think it's becoming easier for all of the reasons you highlighted.
Yeah, actually, you're right, Sean. We saw in some of our research that physicians would not like to bring up the problem of obesity with a patient, whereas when we talked about would you bring up smoking being an issue with a person, and they said, yeah, of course, because that's not good for them for the long term. But for obesity, they actually didn't always want to do that, and that's also because of the stigma. But I think hopefully we can talk so much about it and more about it that stigma is about to go
I think
away.
a multi-layered campaign is required because prevention is actually as the age goes, prevention is better than cure. Any final question? Because we'll be wrapping up soon. Mic here? Yeah, we need the mic for the recording. Thank you. A short question, please. Thank you.
Majid Qaddoumi from Medtronic, and we are in the same space in a different therapy area, more on the surgical side. And I was wondering to understand more, Duffy, from you, since you're connected to people who went through surgery, or purely, what's their experience like on what they don't like on both sides?
Yeah, I mean,
on the surgery side and on the GLP side.
Yeah, for sure. And I think the focus on obesity now is drawing more light to surgical approaches. And I mean, we support many patients and members where they've had, say, a gastric surgery of some sort, and the needs aren't all that different than what we would do for anybody else. So again, I think that I view that as a tool in the toolkit. Now, as you might imagine, someone saying, "Look, I'm going to undergo surgery," is a pretty high bar relative to anxiety. There's more risk factors. So again, I think it has its place, but that's becoming more part of the dialogue.
Right. So with this, we'll conclude the conversation. Thank you for joining us. I think the idea is campaign, educate, and prevent. And I think if we have that in place, then post-problem or post-obesity issues can be tackled much better, but perhaps reduced as well. Thank you for joining us.
Thank you.